This section of lung shows the typical features of Pneumocystis pneumonia. Pneumocystis Jirovecii, previously known as Pneumocystis carinii, is a primitive fungus that is a human pathogen. Pneumocystis is an opportunistic infection that is kept in check by T lymphocytes. And by the age of 4, most people have antibodies to Pneumocystis jirovecii. Pneumocystis forms cysts 3 to 6 microns in diameter with a thick wall and a characteristic thickened point. Patients with an inadequate cellular immune response are at particular risk of developing pneumocystis infection. These include patients with severe malnourishment, HIV/AIDS, transplant patients, patients with hematological malignancies, and those receiving chronic corticosteroid therapy. Pneumocystis pneumonia presents with breathlessness, cough and fever and may progress to hypoxemia and cyanosis, sometimes with pneumothorax, and ultimately pneumocystis may be fatal. Grossly, pneumocystis pneumonia is usually bilateral. There is consolidation of the lungs with sparing of the apices and bases, and there may be cavitation, and it is this that can cause pneumothorax to develop. Histological features of pneumocystis pneumonia include a foamy eosinophilic alveolar exudate, where there are very few inflammatory cells within the exudate, but there is often a lymphoplasmacytic interstitial inflammatory infiltrate. The cysts are present in the exudate and they measure around 5 microns across, and they are demonstrated by staining with Grocott's methenamine silver stain. One of the characteristic features is a dot where the capsule is focally thickened. This is the gross appearance of Pneumocystis pneumonia with consolidation of the lung, and there is also cyst formation. This is this that puts patients at risk of developing pneumothorax. This H&E stained section from a patient with Pneumocystis pneumonia shows the typical features of Pneumocystis pneumonia. The obvious feature is the bubbly eosinophilic alveolar exudates that are devoid of inflammatory cells, but you can see that around them there is quite an obvious interstitial inflammatory infiltrate. And here is a higher power view of the foamy eosinophilic exudate, so typical of Pneumocystis pneumonia. The problem is, however, the Pneumocystis organisms are failing to stain with the H&E. This is a low power view of a section of lung from a patient with Pneumocystis pneumonia stained with Grocott's methenamine silver, and you can see the black dots in the alveolar spaces where the bubbly exudate is. On high power we can see the structure of the pneumocystis cysts. There is a black rim around the cysts, and in many of them you can see the dot where the point of thickening is, and this is a very useful diagnostic feature for identifying pneumocystis cysts. Alternative techniques for identifying pneumocystis on these sections include monoclonal antibody stains and PCR.